Good morning. Good morning. I appreciate everybody giving me an opportunity to talk. I think the Common Table's conversation is a little unique in how we've positioned ourselves in our community. Oh, that is really cool. Did I do that correct or did that correctly? Our mission is very broad-based, and the organization of the Common Table really started in the roots of really population health. So you have to understand where the Commons Table really started, and the mission to mobilize Greater Memphis is very strong and is about everyone. My board is so adamant to use the term all, and it's for everyone. And the vision is something I came on board in 2009 that I put out there to say, let's go for the gold. And basically, we've adopted this vision, and we always get questioned on it, but a vision is something that's aspirational. And in many ways, the Common Table is really positioned in the community as an aspirational organization. So that's very, very important. We're a 17-member board. We are not-for-profits, and we've evolved. When we started off, the board was what I would call a little small clique of people who really just cared about the community, really just cared about the community. But now we're a multi-stakeholder board. It really is a representation of all the stakeholders we meet around the table, including consumers. We work through various projects because we're funded in various ways. So when I think of the work of the Common Table, it's kind of project focused, but we work very hard to integrate it all, and that's my job, to figure out how to integrate it. And we clearly are recognized as the trusted, which is the key word here, multi-stakeholder convener. And it's not on the slide, but we do the public reporting, by the way, thanks to Robert Wood Johnson. I don't know if our community envisioned we would do that, but with a lot of vision for some of the people at the table before I came, we accepted the Aligning Forces for Quality initiative, and we took it on full force, and it's been very effective in our community. We have a website that's focused on not only consumer engagement with this data, but physician engagement with this data, and we do also have it at the patient level, which is challenging, but the physicians want it at that level in order to be actionable. We also produced the first patient experience survey in our market, very challenging. It was done in 2010 with consumer checkbooks, but now we have to figure out how to keep funding that type of work, and we received the same kind of response that Barbara received, and our market was very desirable. People wanted it. We just had to interpret it, which is a major piece of this, and keep doing it. So in 2013, the health plans have agreed to do it again. And finally, we've started to produce what we call Take Charge reports, which is a translation of information in our community that has never existed before. I came from Pennsylvania, and there was a lot of data in that market, thanks to Karen Feinstein. But there's not very much data in the Tennessee market, so we produce data in our local market to talk about non-urgent visits, to talk about ED use, to talk about preventable avoidable hospitalizations, because it did not exist in our market, and we do produce it. So I just wanted people to know that's part of the role we do play. We've made a commitment to the community, and it's very aggressive, and as you can see, the combination of this is to improve, empower, fight, reduce, and eliminate. And somebody's got to give me the acronym. That's what I'm looking for. I don't have it yet. and the key to this is that we have this work in two buckets. And this is the conversation with the board. One is big H. We are always going to be supportive of population health. In many ways, that drives the thinking of my board. It's all about population health. The thinking is we're never going to get the cost out of healthcare if we can't figure out this issue of population health. And secondly is little h, which is the healthcare delivery system focus that we have as a result of the investment of Aligning Forces for Quality and Robert Johnson. So these pieces, in my mind and in the board's mind, fall in those buckets in some way. And some overlap, but this is where the board is, and this is the multi-stakeholder board I talked about. Now, that's why we're in those buckets. We have to be in population health and healthcare delivery. Look at our indicators. This is very challenging for us. This is a community that is very poor. This is a community that has many challenges. We have high obesity rates. We have teen birth rate issues and teen pregnancy issues, high uninsured, violent crime, physical inactivity, infant mortality, high school graduation issues. All are red. Some are moving, some aren't. But this is why we just can't focus on what I would call little h activities. We have to be in this space of population health. So the bottom line is that every time you look at rankings that come out about Memphis and Shelby County, we're in the bottom third. We're in the bottom third. So this really drives the thinking of the board to make sure we can figure out how do we integrate the work we're doing around healthcare quality and improving care and also impacting the care delivery system, but how do we really get at the real root of the problem, which is population health? So that's really the focus, and this whole integration of the patient in this becomes critical because all of the conversations that we have in our community is really focused to the patient, but the providers help us kind of integrate that conversation, but the patients are really the focus. So challenges, look at the dollars. So this helps the conversation. So this whole conversation on data, we start looking at data at a community level, not just at an individual provider level. Both are equally as important. But to really engage policymakers, this is what gets their attention, not the individual results of a doctor, quite candidly. It's about statewide obesity costs being $3.6 billion and doubled since 2009. Everybody's eyes pop out. They pop out when you're in the room and you show those numbers. We started producing information about non-urgent ED use, $130 million, about 300,000 extra visits in our community alone, which is about $660 per visit. Your eyes pop out. That gets people's attention. Potential avoidable hospitalization costs for diabetes, because our diabetes rate is so high, it's about 14%. We think in a community of about 1.3 million people, we have about 110,000 diabetics. So you pay attention. Benefit costs, I don't have a handle around it as much as I would like, but when I talk to people anecdotally, benefits managers, this is the range that we're talking about. But we don't have a number for the community. We know the average number right now is $8,200 nationally, but people say to me they're spending as much as $9,000 for healthcare costs. And then the uninsured, mind-boggling, big number for our community. So we really have to focus on this dual activity of big age and little age. Then we started producing these take charge reports, and I talked about that. And thanks to Aligning Forces for Quality, we convinced one of our hospitals to really look at disparities in their own hospital. And this is really challenging, and they agreed to allow us to publicly report what they learned. And this is what they learned from that report. It was embarrassing to them because this is a hospital system that is seen as the system providing to those in the most need. It's not a safety net hospital system, but it's well regarded. It's a Methodist system for what they do. But we produced this report in the community. We rolled it out at the Civil Rights Museum. It was very powerful because when people look at data at the community level, it's a different conversation. The national data, oh, that's nice. That's a national data. Oh, that's nice. Oh, that's a nice report. And they look at it and they do like, yeah, that's nice. But when they see this came out of Methodist Hospital is having issues of disparity, how could that be? And this really generates the conversation. So our uniqueness in the community as a multi-stakeholder convener is one, they trust the data coming from us, and two, people are willing to give it to us to produce it. Now, I want more data, more data, more data. I really wish more people would give us data, but we do have our champions, people out in front giving us data. I think in terms of our projects, I talked about that. We do organize ourselves in projects, and I think the important thing is that the projects have unique focuses but all integrated. And the patient activation is one of my favorite because I'm absolutely convinced we can engage patients, but we better activate them. So I'm a diabetic, and I don't think I was activated for a long time. And my doctor, when she finally told me I was a diabetic, it didn't activate me right away. But getting her to engage me and then activate me were two different things. It was very, very difficult. So I think this whole notion of activation, we spend a lot of time using the Robert Wood Johnson material, and the approach we take with patients is that we don't meet with people in a room like this. It's too intimidating. We meet in neighborhoods, 15 people at a time. That's what it takes. They're not going to talk in this room. 15 people at a time. That's how you engage patients. That's what really works. And you re-engage them and you re-engage them. It's the only way it's going to work. And they love to be engaged by their providers, by the way. They trust their providers. And providers that are willing to work with us, we engage patients in the physician's offices. They love it. And the providers really love it. So that engagement of patients, it has to be a small, intimate type of environment. So that's really the only thing I wanted to say about that list. Big thing we're doing right now, because of our obesity work, is engaging individuals and organizations around obesity. This is huge for us in our community. And basically, we have an approach where we're engaging organizations to commit to change their vending machines, menu labeling, and doing some activity in the workplace. This is hard, by the way, but it's easy. It's hard but easy. And it's individual responsibility, but you have to create an environment that people can go to. If I'm going to say I'm going to have a healthier initiative in my organization, and I walk downstairs and the vending machine is full of junk food, how crazy is that? I sat down with HR people, and they're complaining about their healthcare costs. Oh, my people are so obese, and they're using the emergency room. And I go down and say, let's walk downstairs, and I take my camera with me. And we walk downstairs, and I take pictures of the vending machines, and I said, I'm going to send those, I'm going to email it to you. And I emailed it to them, and I put little smiley faces on it. And I say to them, see, if you could change this environment, we can really work with you on your healthcare costs. Don't talk to me about benefit redesign until you redesign this environment. Benefit design is not going to do it. You got to do this environment as well. So that's kind of our thinking when we try to integrate big H and little h, and really think about the individual who's going to be impacted by those changes. And Harold said to me, kind of, Renee, what are some of your impacts? And I just pulled some ideas out. One is that we really have a lot of focus on the hospitals because it's important. We do have all the hospitals working together on a quality improvement plan. Our big focus has been on primary care practices and quality improvement. When I came in 2009, I really could not document that practices were doing quality improvement. They didn't know what it was about. But we do now have 10% of the practices involved in quality improvement through Common Table, through their health plans. It is now moving, but we are slow. We're behind. Farmers markets, I'm very proud of that, because when you think about population health, access to healthy food is very important. We all take it for granted. We all have it, but many communities don't. And we've also been staying focused on our ability to drive down obesity and increase transparency. And I must say, transparency is probably the key aspect of the work that we've done in Memphis, because it did not exist when I came in 2009. There was just no data, nobody talking about the things that we're talking about today. So that's been very, very important. And engaging consumers, engaging individuals is key to our strategy. That's very key. And people act different, by the way, when consumers are in the room. I've learned that. And doctors in the beginning did not want consumers in the room. It was very uncomfortable, but now they want them. Thank you.